Good day everyone. Today we will be continuing our journey in the river of hematology. We will be dealing with the anemia types after you have taken the course for the erythropoiesis and the general aspect of anemia, how to reach a diagnosis in the case of anemia. We'll be more specific, and today our topic will be microcytic anemia. I'm Muhammad al-Baghdadi, lecturer of clinical hematology, and will be your guide during this trip. I hope that every one of you and your beloved is safe and healthy during this epidemic of. These are my contact information. As you have already known, WHO defines anemia as a hemoglobin level below 13 grams per liter in men and 12 grams per liter in female. The critical elements of erythropoiesis are used for the initial classification. Of course, we have some immature cells, like the pro-normoplast, to be the early cells. Then we have polychromatic cells. Later, we have some pycnotic cells, and reticulocytes are the last cells to be present in the bone marrow before shedding its nucleus and getting the red blood cells. So, erythropoiesis is requiring at least 58% or more of the erythroid activity to be in balanced incorporation of heme and globin to form hemoglobin. The immature nucleated RBCs must have an adequate supply of iron, as well as normal production of porphyrin and the globin polypeptide chain for adequate synthesis of hemoglobin. Folic acid and vitamin B12 are also needed in adequate amounts to maintain proliferation and differentiation. Defects may occur at any stage of development, and these defects will lead to the death of the cell. Anemia actually is a sign of a disease process rather than a disease itself. So, how do we measure anemia? As you have already known, we measure the hemoglobin per 100 milliliter of whole blood. Then we measure the hematocrit, which is a percent of sample of whole blood occupied by intact red cells. Then also the measure for the RBCs in million cells per microliter of the whole blood. And afterward we measure the mean corpuscular volume, which defines anemia according to the size of the cell, either to macrocytic, normocytic, or microcytic. And also we have to measure the red cell distribution, which is known as the RDW, which is normally from 11 to 15%, and if it is elevated, it suggests large variability in the size of RBC. As we have mentioned, RBC anemias can be classified either into size classification, microcytic, normocytic, or macrocytic, depending on their MCV, or by the presence of the reticulocytes to assess the red blood cells regeneration, either hyporegenerative if there is decrease in the reticulocyte, or regenerative if there is increase in the reticulocyte, which means that there might be some sort of early destruction of the RBC. So, when tackling a case of anemia, we have to do a CBC and the reticulocytic count. If we have an increased reticulocytic index more than 2.5, means that there might be some hemolysis or hemorrhage, and the bone marrow is trying to compensate such disorder. If it is low, it means that there is a problem with the red cell morphology, either being normocytic or microcytic or macrocytic. Microcytic and macrocytic are mainly due to deficiency in the nutrients, mainly the iron and the vitamin B12 and vitamin B6, while normocytic due to a problem in the factory itself in the bone marrow or in the stimulus itself. So we will be dealing today with the cytoplasmic defects like the iron deficiency, the thalassemias, and the sideroblastic anemias, and anemia of chronic lymphocytic anemias. Using the MCV, the impaired cell division process allow a normal intracellular hemoglobin concentration to be achieved after a low number of cell division, thus resulting in microcytosis. While if the hemoglobin synthesis is defective, the immature RBCs will divide more times than during the slower hemoglobin production process, thus resulting in smaller RBCs, microcytosis, which is happening in iron deficit. So either we have a defect in the iron, leading to iron deficiency anemia due to the lack of the iron to be provided to the bone marrow, or Also, there is failure or release of the iron from the macrophage, leading to decrease in the iron in the heme component, or we have a defect in the porphyrin synthesis, which result in sideroblastic anemia, or in the globin part synthesis leading to thalassemia. These are the causes for the microcytic anemia. Iron anemia is the main cause and the main contributor to the microcytic hypochromic anemia. We have the iron cycle. Iron is mainly absorbed from the duodenum in a rate of about 1 milligram per day. This iron is carried by the transferrin in the plasma, so it carries it either to the bone marrow to form new RBCs, and these RBCs are later transformed into circulating hemoglobin to be either lost in hemorrhage or menstrual loss, or to be degraded by the macrophage. Then the free iron will be carried back by the transferrin in the plasma and will be transported to the liver and other parenchymal cells and tissue, especially in the muscles, myoglobin, to be excreted afterwards in the urine or the faces, nails, hair and skin in the same rate it has been absorbed. So if we look for the distribution of the body iron, we will find that the hemoglobin forms about 65% of the total absorption, total iron concentration, the ferritin and the hemosiderin 30%, myoglobin 3.5%, and the last 1.5% is divided between the transferrin bound iron and the heme enzymes like cytochromes and catalases. What will affect the iron absorption? We have factors favoring the absorption like inorganic iron, iron being in the ferrous form, the reduced form, having an acidic media, having a solubilized agent like sugar and amino acids, reduced serum hepcidin, ineffective erythropoiesis, pregnancy, and hereditary hemochromatosis, which having high affinity for iron absorption. On the other hand, having a heme iron or a ferric iron, which is the oxidized form, alkaline media, precipitating agent like phytates and phosphates and T, increased serum hepcidin, and decreased erythropoiesis and inflammation, all will lead to reduction in the iron absorption. How about the daily requirement for iron? Mainly for an adult female or a male is from 0.5 to 1 milligram per day. For a menstruating female it raises to up to 2 milligrams. For a pregnant female up to 3 milligrams, and for the children it's 1.1, while in the adolescent female it's up to 2.6. What might be the causes for the iron deficiency anemia? The first of all is the chronic blood loss, mainly due to uterine causes for abnormal menstruation. Secondary is the gastrointestinal bleeding, through peptic ulcers, esophageal varices, use of non-steroidal anti-inflammatory drugs, gastrectomy, having a malignancy in the stomach or the cecum or the colon or the rectum, having a hookworm, bilharziasis, angiodysplasia, or inflammatory bowel disease. All of these lead to chronic blood loss. Rarely hematuria and hemoglobinuria, pulmonary hemosiderosis, and self-inflicted blood loss might cause iron deficiency anemia. The second item is the increased demands, either prematurity or growth, or in pregnancy, or patient taking erythropoietin therapy. The third cause might be malabsorption, like the gluten-induced enteropathy, gastrectomy, or autoimmune gastritis. Poor diet is a major factor in many developing countries, but rarely it accounts for the main cause in the iron deficiency anemia. It should be combined with other causes. So, in this cartoon, we see the regulation of iron absorption. We have the dietary iron in the form of the ferric form. The oxidized form should be reduced first to ferrous to enter the enterocytes through the divalent cation binder. Its export into the portal plasma is controlled by ferroportin. It's oxidized before binding to the transferrin in the plasma, and heme is absorbed after binding to the receptor protein. What are the stages of iron deficiency? We have a pre-latent stage where there is reduction in the iron store without reduction in the serum iron level, where there is no anemia, normal MCV, with increased iron absorption and low serum ferritin and low marrow iron. Then we have a latent anemia, iron deficiency, where the iron storage is exhausted but the blood hemoglobin remains normal, and then the overt iron deficiency anemia, where the hemoglobin level falls below the lower limit for normal and all the indices will be decreased except for the total iron binding capacity will be elevated. Here is a cartoon showing the latent, the pre-latent, the latent, and the manifest iron deficiency anemia. Here the depletion only of the iron bone marrow stores, while the RBCs are still intact. Later on, the RBC become hypochromic microcytic with the same depletion occurring. So what might be the symptoms for iron deficiency? Irritability, poor attention span, lack of interest in surrounding, poor work performance, behavioral disturbance, pica, which is specific for iron deficiency, defective structure and function of the epithelial cell leading to loss of hair, discoloration of the skin and nails, tongue will be glazed, the mouth and hypopharynx and stomach all will be subjected to ulceration and increased frequency of infection. What about this pica? This is habitual ingestion of unusual substance. Some might have agiophagia, where they are subjected to eating clay or dirt. Some might be having amylophagia, eating the laundry starch, the detergent. Bigophagia, eating ice. Usually it's a manifestation of iron deficiency and is relieved when the deficiency is treated. By the physical examination, pallor is the main manifestation in the skin, lips, and nail beds and conjunctival mucosa. Nails will be flattened, fragile, brittle, having what's known as conychia and even spoon-shaped. Tongue and mouth are subjected to glossitis, angular chelosis, stomatitis. Dysphagia might be caused by Plummer-Vinson syndrome. In the stomach, atrophic gastritis might be seen. The cause for these changes in iron deficiency is uncertain, but may be related to the iron requirement of many enzymes that help in repair of this epithelial and subinsular. Here we can see the pallor, of course, and the stomatitis and angular chelosis. Here we are having the conychia and spoon nails. What are the investigations to be done? Of course, CBC, it will be showing microcytic hypochromic anemia. A blood film will be showing to us microcytic cells and hypochromic with occasional target cells to be devoid of the pigmentation. Here, this is the dimorphic blood film showing a patient with iron deficiency under treatment, where some of the cells have recovered while the others are still microcytic and having the target cell appearance. Iron profile, of course, this is the main diagnostic test and will be discussed later. Bone marrow aspirate will show a decrease in the iron content. As we can see on the right here, we are having normal iron stores pigmented by blue, and here there is deficiency in the iron stores with no. How about the iron test? Of course, low serum ferritin is the almost always indication for iron deficiency. Low serum iron with high total iron binding capacity is also an indication for iron deficiency. Ferritin more than 100 is rarely found in iron deficiency, except in liver inflammation and necrosis. Normal serum iron is rarely found in iron deficiency, except when patient is under treatment. When TIBC, total iron binding capacity, is low or normal, low serum iron is not reliable indicator for iron deficiency. Iron deficiency may be hard to diagnose via blood test in settings of inflammation where there is low iron, low TIBC with intermediate ferritin level. A therapeutic trial of iron plus or minus erythropoietin may be a reasonable alternative for bone marrow. So, in a case of iron deficiency, to summarize, the ferritin will be low, the serum iron will be low, with increase in its total iron binding capacity, and the percentage of saturation is low, and the reticulocyte is either low or normal. While in the anemia of chronic inflammation, ferritin might be normal or high, with low serum iron, low TIBC, and percentage of saturation is also low, and the reticulocyte count was the same. While in Sarracenia, we are having high reticulocyte count with low elevated ferritin to normal ferritin, and of course normal to low total iron bind capacity. Here is a cartoon showing the normal distribution between the serum iron and the iron binding capacity and its interpretation of the serum ferritin. Here normally we are having a balance between the serum iron and the iron binding capacity with normal ferritin level either for male or female. When iron deficiency is present, we have a low serum iron with increase in the iron binding capacity and serum ferritin is low. In anemia of chronic disease, there is slight decrease in the serum iron with slight increase in the iron binding capacity with elevation in the serum or normal serum ferritin, while in other iron overload, the serum iron is highly elevated with low iron binding capacity and of course high serum ferritin. So how do we manage a case of iron deficiency anemia? We have to correct the iron deficiency by supplementation, either orally, intramuscular injection or intravenous injection, while the main landmark is treatment of the underlying disease, either treating the diet or checking for the source of bleeding and correcting it, or the malabsorption that led to this or any infection that led to iron deficiency. So having a hypochromic microcytic anemia confirmed by low serum iron and raised TIBC with low serum ferritin, in a female I shall check for uterine bleeding in menorrhagia or repeated pregnancies. In a male I will check for gastrointestinal blood loss either in occult blood test or upper or lower GIT endoscope. Then I will be treating the cause of this bleeding and then supplementation with oral iron, mainly ferrous sulfate to correct anemia and replenish stores. Rarely parenteral iron is required. So who needs the gastrointestinal workup? All men, all women without menorrhagia or abnormal uterine bleeding, women greater than 50 years with menorrhagia. If upper GIT symptoms is present, upper GIT endoscopy is done. If not, colonoscopy is done. While women less than 50 with menorrhagia will be considered having a gastrointestinal workup upon symptomatic presence of these symptoms of the gastrointestinal upset. So, iron therapy, the optimal dose is 200 mg of elemental iron. We have ferrous gluconate, fumarate, or sulfate. Iron is absorbed more completely when the stomach is empty. It's necessary for the treatment to continue for 3 to 6 months after the anemia is relieved. Iron absorption, as we mentioned, is enhanced by vitamin C, meat, orange juice and fish, and of course precipitated by the milk, tea, and cereals. Side effects might include heartburn, nausea, abdominal cramps, and diarrhea. Why do some patients fail to respond to iron? Continuing hemorrhage, the cause is still there. Failure to take the tablet, incoherence to the therapy, wrong diagnosis, especially if the patient has thalassemia trait or sideroblastic anemia, he's taking the wrong medication. Patient is having mixed deficiency, so patient is only taking iron while he should be subjected to vitamin B12 and folic acid. Another cause of anemia is associated with the iron loss, like malignancy or inflammation. Malabsorption, having a celiac disease or atrophic gastritis or even a helicobacter infection. Use of slow release preparation and abnormal preparation. So if there is a normal preparation or a failure to iron, oral iron therapy, parenteral iron therapy is an option, but is indicated only in patients who demonstrating intolerance to oral iron or lost iron at a rate rapid for the oral intake, or has a disorder in the gastrointestinal tract, or unable to absorb iron from the gastrointestinal tract. We have many preparations. We have iron dextran, either given intramuscularly or intravenously. Necessary is the test for hypersensitivity in such a preparation. The maximal required daily dose is 100 mg for 2 milliliters. The total dose required for the parenteral iron is calculated from the amount of iron needed to restore the hemoglobin deficit and to replenish the store. So iron to be injected in milligrams is equal to 15 minus the patient hemoglobin by the weight of the patient by 3. So if this patient is having a hemoglobin of 10 and his weight is 50 kilogram, so he will be receiving 5 by 9. He will be requiring 45 milligram of iron to be injected. What are the side effects for the parenteral iron therapy? Locally, pain at the site of the injection, discoloration of the skin, lymph nodes becomes tender, pain in the injected vein, flushing, and the metallic taste, and systemic symptoms or side effects, which might be immediate like hypotension, headache, malaise, urticaria, nausea and anaphylactoid reaction, or delayed like lymphadenopathy, myalgia, arthralgia, or fever. So we have finished our first part of the microcytic hypochromic anemia. So our second type will be the thalassemia. Hemoglobin abnormalities in general result from sense of an abnormal hemoglobin or reduction in the rate of the synthesis of normal alpha or beta globin chains, resulting in alpha and beta thalassemia respectively. Here are the normal subunits, the beta subunits, and the alpha subunits, and this is the normal structure of the hemoglobin, having the iron and the 4 globin chains to be surrounding it. As you have already known, adult hemoglobin is composed of 2 alpha and 2 beta chains. In thalassemia, alpha of course is carried by the chromosome 16 and it comprises of 4 genes, while the beta subunit is carried on chromosome 11 and is composed of only 2 genes. Alpha thalassemia occurs when a gene or multiple of the 4 related to the alpha region protein is missing or mutated, while the beta happens in the chromosome 11 in the beta subunit. As we can see, here is the normal hemoglobin concentration constitution of 4 alpha subunits and 2 beta subunits. When we are defective in the alpha subunits, we are having alpha thalassemia, which varies from hydrops fetalis, where there is no alpha thalassemia and this is incompatible with life, to hemoglobin H, which is having only one copy of the alpha subunit, to alpha thalassemia trait having only defective 2 or 1 alpha subunits, while if the beta is defective, this is a beta thalassemia. If there is no beta subunits, this is a beta thalassemia major. If there is only 1 beta subunit, it might be a major or intermediate, while having a disrupted or a reduced beta subunit will lead to a beta thalassemia trait. This is the distribution of hemoglobinopathy worldwide. As we can see, the sickle cell anemia is abundant in Middle Africa, while hemoglobin C is in the west coast of Africa. Hemoglobin D is present in the Indian Peninsula, and as we have seen, hemoglobin thalassemia is a major hemoglobinopathy to be present, of course, in the Mediterranean Sea and the Arabic Peninsula and throughout Southeast Asia. Beta thalassemia, as I have mentioned before, each one of us inherit 1 gene from each parent. So we are having 2 copies of the beta gene. You might be homozygous, having normal both beta genes, or heterozygous, having 1 normal and 1 abnormal, either it is reduced or mutated or absent, or you are diseased, having homozygous, abnormal both gene being abnormal or mutated. This is the beta thalassemia major. So beta thalassemia, the clinical manifestation of the thalassemia major, typically start with the first year of life, when the reduced beta or the absent beta chain, there is relative excess of unbound alpha globin chains that precipitate an erythroid precursor in the bone marrow, leading to their premature death and then ineffective hematopoiesis. Thalassemia major have a prominent landmark, which is the bone change. As we can see here, this is the bossing of the frontal and the parietal bones, with the maxilla being enlarged, and compensatory expansion of the marrow can be prevented by transfusion. While here a skull X-ray having a patient without chronic support, transfusion support, having what's known a hair on end appearance, which is pathognomonic for thalassemia, beta thalassemia major. So the clinical picture of a case with beta thalassemia major is having severe anemia at 3 to 6 months after birth, when the switch from gamma to beta chain production should take place. Hepatosplenomegaly due to red cell destruction, extramedullary hematopoiesis, and iron overload. Expansion of the bones caused by the intense marrow hyperplasia leading to a thalassemic facies and to thinning of the cortex of many bones with tendency of fracture and bossing of the skull with the hair end appearance as we have seen. Liver disease and hepatocellular carcinoma related to HCV infection, HBV and HIV. Also iron overload. Osteoporosis may occur in well-transfused patients. It's more common in diabetic patients with endocrine abnormalities. Organ systems susceptible to iron overload due to the recurrent transfusion, the pituitary leading to impaired growth and infertility, the thyroid leading to hypoparathyroidism, the heart leading to congestive heart failure, cardiomyopathy, and cardiac dysfunction, the liver leading to hepatic cirrhosis, the pancreas leading to diabetes mellitus, and the gonads leading to hypogonadism. Iron overload and end organ toxicity is inevitable in the absence of intervention therapy, and this is the most dangerous complication of thalassemia. So, patient who's having a deformed RBCs is having three main problems: ineffective erythropoiesis, the hemoglobin is disrupted leading to hemolysis, and a hypercoagulable state due to this hemolysis. So, ineffective hematopoiesis will lead to anemia, will lead to cortical thinning in the bone marrow expansion, and extramedullary hematopoiesis leading to bone pains and fracture, hepatomegaly, and splenomegaly. The hemolysis will contribute to the anemia, will lead to the formation of gallstones, and will have increase in the absorption of iron and in iron deposition in visceral organ, and the parathyroid gland and thyroid, pituitary, and the pancreas and the testis and ovary, leading to endocrine dysfunction, and the liver leading to cirrhosis, and the heart leading to arrhythmia and heart failure, while the hypercoagulable and the platelet dysfunction will lead to thromboembolism and vascular dysfunction in thalassemias. In the laboratory diagnosis, we have a severe hypochromic microcytic anemia with normoplastemia, target cells, and basophilic stippling in the blood film, as we have seen here in this figure. A patient with beta thalassemia. Hemoglobin electrophoresis diagnostic test for any hemoglobinopathy. It shows absence or a almost complete absence of hemoglobin A, all the circulating hemoglobin being hemoglobin F, and hemoglobin A2 percentage is normal or low or slightly raised. Here we can see this is the peaks of the hemoglobin electrophoresis differing. Here we are having the normal person having hemoglobin A comprising the main component in the hemoglobin with decreased F and elevated, and hemoglobin A2 forming 3.5% of the hemoglobin. A patient with beta thalassemia major will be having absence of hemoglobin A with increase in hemoglobin F and slight increase in hemoglobin A2, while those with thalassemia trait will have a larger part of the hemoglobin A2 and hemoglobin A with elevation in the hemoglobin F above its normal percentage, which is 0.5%. And in sickle cell trait we are having hemoglobin S. We are having also some of the sickle cell thalassemia which will be dealt with the normocytic normochromic anemias. DNA analysis is used to identify the defect on each allele either in chromosome 11 in beta thalassemia or chromosome 16 in alpha thalassemia, and it's the cornerstone of antenatal diagnosis. Clinical and laboratory evaluation for a patient with thalassemia, especially an adolescent, should be doing compatibility test before any blood transfusion, physical examination and blood count at each transfusion, serum ferritin every 3 months, growth assessment and empirical assessment and ECG every 6 months, and yearly red cell requirement should be measured, virology and abdominal ultrasound should be done, endocrine function evaluation, chelation, toxicity, ophthalmology examination and urology examination, and echocardiography. So, the treatment of case of thalassemia depends on regular blood transfusion to maintain the hemoglobin about 100 grams per liter, usually requires 2 to 3 units every 4 to 6 weeks. Fresh blood filtered to remove white cells give the best results in the survival and the fewest reaction. Iron chelation therapy is an important and pivotal to improve the life expectancy and decrease the comorbidity that might happen. Folic acid is required, 5 grams per day is given if the diet is poor. Splenectomy might be done to reduce the blood requirement and should be delayed until the patient is above 6 years to gain the benefit from the immunological function of the spleen, and afterwards the patient post-splenectomy should be having vaccines. This, what are the vaccines? We are having the pneumococcal vaccine to be given every 5 years, and Haemophilus influenza vaccine should be given before the spleen but not required afterwards. The influenza vaccine might be given annually and as soon as available for seasonal precaution. How about the iron chelation? Chelation should be started after the first 10 to 20 transfusion, or if the serum ferritin is above 1000. We have 3 chelators, 3 generations. The first one is desferoxamine, the second is defibron, the third is devrazirox. Desferoxamine is injection, it's subcutaneous injection or intravenously, while defibron and devrazirox are oral. The half-life for desferoxamine is 20 to 30 minutes, so it's given by continuous infusion over a long period, while for the oral formulas, the defibron and devrazirox, the half-life for defibron is 3 to 4 hours, so it's required to be taken every 6 hours or so, and the devrazirox might be given every 8 to 12 hours. It's mainly excreted urinary, the desferoxamine, while the defibron is urinary and the devrazirox is fecal. The side effects, of course, injections at the site of injection for the intravenous and potential ocular or otic toxicity. Defibron might cause a granulocytosis, and devrazirox may cause renal insufficiency in 1/3 of the patient and gastrointestinal disturbances. Of course, all patients are required for the chelation, and you tailor the chelation by which drug according to the efficacy. Of course, the devrazirox is the most efficient, followed by the defibron, then the desferoxamine, and the comorbidities that are happening in the patient, which will guide your selection. Endocrine therapy is given either as a replacement because of organ failure or to stimulate the pituitary if puberty is delayed. Diabetes requires insulin therapy. Patients with osteoporosis may need additional therapy with increased calcium and vitamin D, together with a bisphosphonate and appropriate endocrine therapy. Allogenic stem cell transplant offers a prospect of permanent cure, but the patient age is a factor affecting outcome. The liver size, the presence of fibrosis, and adherence to chelation, all of these young age, small liver size, and small or absence of fibrosis, and well-chelated patient will have a better prognosis than their counterparts. What is the indication of splenectomy in a case of Thalassemia intermediate? Gross failure or poor performance at school, so decrease the transfusion need, transient stressful condition like pregnancy or infection, having symptomatic anemia or leg ulcer, while if there is growth retardation or poor health, leukopenia, thrombocytopenia, or increased transfusion demand or symptomatic splenomegaly will indicate splenic. Alpha thalassemia, caused by alpha globin gene deletions or less frequently mutations, as we have seen and mentioned before. We have four chains of alpha chains, as we mentioned. Normally they are present, having alpha trait when one is absent, a homozygous when both were absent from the same gene, while having a hemi loss is mentioned as alpha 0, while the loss of 3 is mentioned as pars hemoglobin H, while hydroxy fetalis is the loss of the 4, and as we mentioned, is incompatible with life. The clinical severity is related to the number of the 4 alpha globin genes missing or inactive. As we mentioned, the loss of the 4 of them, death in utero, hydroxy fetalis, 3 gene deletion, a moderately severe hemoglobin from 8 to 9 microcytic hypochromic anemia, as known with splenomegaly, a case of hemoglobin H. Here we have a case of hemoglobin H with the blood film showing microcytic hypochromic anemia. with target cells and poikilocytosis, and here with supravital stain we can see the deeply stained deposits, the golf ball cells. Alpha thalassemia traits are caused by loss of one or two genes and are usually associated with anemia. MCV and MCH are low, and hemoglobin electrophoresis is normal in such patients. DNA analysis is needed to confirm the diagnosis. What will be the treatment of such cases? It will be folic acid, splenectomy if required, and of course blood transfusion when needed. Our third type of anemia, which is microcytic hypochromic, is a sideroblastic anemia. These are a heterogeneous group of anemias defined by the presence of ringed sideroblast in the bone marrow. It's either hereditary, as a type of porphyria, or leads to myelodysplasia, or after drugs as isoniazid and chloramphenicol. The hereditary type is an X chromosome linked alpha aminolevulinic acid synthetase mutation, and rarely with spinocerebellar degeneration and ataxia. Occurs usually in male, transmitted by females, occur rarely in females. Other rare autosomal type involving mitochondrial protein or thymine phosphorylation might be present. How about the acquired? It might be primary or secondary to myelodysplasia, refractory anemia with ringed sideroblast, or other malignant disease of the marrow like myelofibrosis or myeloid leukemia or myeloma. Drugs as anti-tuberculous drugs, as we mentioned, isoniazid and cycloserine, alcohol, lead, or other benign conditions as hemolytic anemia, megaloblastic anemia, or rheumatoid arthritis. This is the ringed sideroblast, as we have seen, with a peculiar ring in front granules over the sideroblastic anemia. Treatment of sideroblastic anemia is, of course, treating of the cause of the secondary or the acquired. Here we have anemia of chronic disease, which is one of the microcytic hypochromic anemias in 2/3 of the cases, and in 1/3 it is normocytic normochromic. This anemia might appear from bone marrow involvement or distribution defect of the iron, or shortened erythrocyte survival time, or depression of erythropoiesis or erythropoietin production, either cytokine mediated or not, having a cytotoxic chemotherapy, or a pleural aplasia, usually associated with T-cell non-Hodgkin lymphoma, or hemolysis is a part of the non-Hodgkin lymphoma or a chronic lymphocytic leukemia, or even renal failure, which might happen with multiple myeloma. All of these contribute to the anemia of chronic disease. So, what might be the causes? As we mentioned, chronic inflammatory disease, infections, pulmonary abscess, tuberculosis, osteomyelitis, pneumonia, or bacterial endocarditis, non-infectious causes as rheumatoid arthritis, systemic lupus, and other autoimmune connective tissue disease, congestive heart failure, pulmonary disease, renal disease, of course, obesity, any malignant disease associated with sarcomas, lymphomas, and carcinomas. So, what will be the landmark difference between cases of hypochromic anemia? We have the iron deficiency, anemia of chronic disease, the thalassemias, the sideroblastic anemia, or iron refractory iron deficiency. As regards the MCV and MCH, they are all reduced, of course. They are microcytic anemias and hypochromic anemias, except for the normocytic normochromic part of the anemia of chronic disease. For the RDW, it's raised in the iron deficiency, the sideroblastic anemia, and the iron non-refractory iron deficiency, while it is normal in the thalassemias and the anemia of chronic disease. The serum iron is reduced in iron deficiency and anemia of chronic disease, while it's normal or raised in the thalassemias, and it's raised, of course, in sideroblastic anemia. As regards the total iron binding capacity, it's raised in the iron deficiency, reduced in the anemia of chronic disease, normal in the case of thalassemia trait, and elevated and reduced in cases of overt thalassemia, normal in sideroblastic anemia, and reduced in non-refractory iron deficiency. The serum ferritin is reduced in iron deficiency, normal raised in anemia of chronic disease, normal in thalassemia, while it is elevated, of course, in the trait is normal, elevated in the overt, elevated or raised in the sideroblastic anemia and raised also in the non-refractory iron deficiency. The bone marrow iron are absent in the iron deficiency and present and even more augmented in sideroblastic anemia. The erythroblast iron is absent in the iron deficiency and the anemia of coronary disease is present in case of thalassemia and is present in ringed forms in cases of the sideroblastic anemia, having the term ringed sideroblast. For the hemoglobin electrophoresis, it's normal in all of these types, but for the thalassemia, if the thalassemia traits, there will be raised in the hemoglobin A2 with slight raise in the hemoglobin F, while if it is a pure thalassemia or a thalassemia major, it will be elevation in the hemoglobin F with absence of hemoglobin A and slight raise in the hemoglobin A2. For the RDW, it's raised, as we mentioned, in the iron deficiency and the sideroblastic anemia, while it's normal in the thalassemia trait and the anemia of chronic disease. With that, we have finished our microcytic anemia. My advice to you during this time is to stay home and stay safe. I hope that this material has helped you and all of your family and all of your loved ones are safe and healthy during these times. Thank you for your attention and have a nice day. Thank you.